Thanks everyone for joining. Our speaker for today's seminar is RaeAnn Anderson. A few brief introductory remarks. She received her PhD from the University of Wisconsin-Milwaukee in 2015. She also completed postdoctoral training at Kent State University, and she's currently an assistant professor of clinical psychology at the University of North Dakota. Her research interests lie in the areas of methodological issues related to sexual violence research. She looks at basic behavioral processes and sexual victimization and sexual perpetration in order to inform sexual assault risk reduction and prevention programs. And the title of her talk today is Alcohol-Facilitated Sexual Victimization Among Indigenous College Students. I will turn it over to her. And I will say at the beginning here that if you have any questions, please use the chat box, and we will read those questions aloud for Dr. Anderson to respond to. So thank you, Dr. Anderson, for being here today, and I will turn it over to you.
Thank you, David. Thank you all so much. I am a bit floored trying to keep upright here, being introduced by someone whose research I read very closely for my dissertation, and now I'm being invited to present at the University of Nebraska. Very honored and delighted to be here. And as David said, if you have clarifying questions as we go, please drop them in the chat and Callie will bring my attention to them so that you hopefully get the most out of this presentation as we go. So I'm focusing on our alcohol-related data today from the Self-Defense for Indigenous People study. Tagline, sovereignty for your body. And this is our study logo made by Suta Collinglass of the Indigenous Vision organization, who gratefully let us use this. I also want to shout out to our team, which is primarily Indigenous, representing folks from the Hunkpapa Lakota Nation, the Citizen Band Perry Potawatomi, the Muskogee Nation, the Sisseton Wahpeton Oyate, and the Turtle Mountain Band of Chippewa. And special shout outs to my co-PI, Ashley Cole at Oklahoma State. I would never have done this research and proposed these grants without her help. And we met on academic Twitter. So this might be the one tale of positive social media influences. So presenting to the RDAR exchange and doing this research on rural America has been kind of a wild ride because I'm from rural America. I was raised in Circleville, Kansas, which is a population of about 20, and I grew up trying to convince my parents to let me ride my bike 3 miles into town so that I could see some friends. And I didn't really understand that rural people were of interest to researchers or had particular cultural or health issues until recently, until I joined the University of North Dakota. So enough about me. Some background for this presentation. It might be hard to pick out Lincoln on this map, but Lincoln is on this map. This is a map of the historical indigenous lands in the United States. You can start to pick out where we are based on where Lake Superior and Lake Michigan is. It's kind of how I find where I am. I like to show this to start setting the tone for this presentation. That we're going to be taking a different lens, and a different set of assumptions into some topics that we are already familiar with. So I'll give some background before I get into the goals of this study. Our methods, focusing some results on alcohol-facilitated violence, and then intervention preferences. all of my transection slides today are flags from the nations of the folks on our team. So starting with background, Turtle Mountain Band of Chippewas, the nation probably closest to University of North Dakota. So if I can have a little audience participation, and I can't actually see any of you, so let's see how this works. Who is the most famous Indigenous woman that you know?
And RaeAnn, I might even say folks attending here, feel free to put your answers in the chat, and then we can maybe see answers to your questions there. So for the last question, who is the most famous Indigenous woman you can think of? Feel free to stick that in the chat, folks.
Susan LaFleche Pico. I believe there's a named chair for her at the medical school, right? Outstanding example. Any other examples? Sacagawea. Another great example. Any Disney inspiration in the crowd? Yeah, Pocahontas is kind of, and this might be my growing up in the 90s and 2000s perspective. Pocahontas is kind of the first person I think of. Pocahontas is, I don't think any of us think that the Disney tale was realistic, but the degree of departure from real life in this case is horrific. Pocahontas was one of the first Indigenous women to be kidnapped, to be trafficked, to be raped. None of that is present in the Disney tale or in kind of white America's discourse of who was Pocahontas. And I think that's really an important context for thinking about sexual assault on Indigenous lands. This has been something that's been happening for a very long time. And the solutions are complicated. So it starts with Pocahontas. It continues today, the missing and murdered Indigenous women movement. Native American women are not only most likely to experience rape of all racial groups in the US, they're also the most likely to be murdered. Which relates to this idea of historical trauma and loss that you'll see a lot in research with Indigenous folks, of this ideas of these generations of losses and traumas that feel very present and are very present in many ways. That said, I also want to make sure that we recognize the diversity of tribes in the US. There are 538 federally recognized tribes in the US. And there's additional tribes that aren't federally recognized that have chosen to not participate in the federal benefits system. So there is such diversity and strength. It's hard to say any one thing about Indigenous people. And then finally, there is Indigenous people are one of the few groups in the US who predominantly live in rural areas, right? Rural Americans are in general a minority of the population, actually the majority when we think of Indigenous folks. Although of course there are still many urban Indians, and we don't want to ignore that either. Further, Indigenous folks have sometimes been called the invisible minority, the minority group that people kind of forget exists sometimes. For example, voting rights for Indigenous people were not federally protected and recognized until 1977. And in fact, there's been some rollbacks, including in the state of North Dakota, so named for the Dakota people, where it was recently made very difficult to get voter registration ID on reservation lands. Boarding schools, the 60s scoop, where children were taken from their homes and taken to boarding schools, erasing their culture, traumatizing them. And related to that, the Indian Child Welfare Act, which tried to, and still exists, to stop that process. And this has created, these health education disparities that we're now trying to solve. So particular to sexual violence, 56% of Indigenous women and about a quarter of Indigenous men have experienced sexual victimization in their lifetimes. If you think about past year, it's a little more than 10% for women and about 10% for men in just the past year, right? For some racial groups, that's the lifetime estimate. So not only is rape occurring frequently against Indigenous people, the context of it is different. Indigenous people are much more likely to be raped by someone outside of their racial group, and it's more likely to be physically violent and result in injury. And Indigenous children are more likely to have been sexually abused. So this is a pattern, a cycle that begins early in life. Many of you may know this, but just to put some numbers on it, experiencing sexual violence, particularly rape, increases the risk of every mental health disorder that we have studied in relation to its occurrence. About 40 to 50% of women who experience rape will be diagnosed with PTSD in the year afterwards, or I should say meet criteria. 19% lifetime prevalence for substance use, 40% prevalence for depression in lifetime, and 24% in the last year. So of women who have experienced rape, 24% of them will have been depressed in the last year, which suggests that on average, 25% of Indigenous women and 13% of Indigenous men have rape-related PTSD. And that is not accounting for how repeated victimization increases the risk of these disorders. In relation to substance use, according to NESARC data, Indigenous people drink less than white folks, but more than Asian folks, tend to be in the middle or middle high part of the pack if we're comparing racial groups. But the highest rate when we drill down on heavy drinking specifically. Relevant to the data I'll present today, that's with college students. Indigenous college students may actually drink less than white students. And rape, substance use, this is an example where discrimination and stereotypes do impact people's health. Belief in the fire water myth that Indigenous people are biologically more vulnerable to alcohol consumption is actually associated with worse outcomes in spite of greater attempts to quit. Really interesting study by Gonzalez and Skewis that showed that people who knew this wanted to quit, tried to quit, but they had worse self-efficacy to be able to quit. So given this context, given this background, reducing risk for rape is a different ball of wax. This is a different setting, different context than what we might traditionally think of for reducing rape for college women. And note here, I'm saying Indigenous peoples, I'm specifically including men and Two-Spirit folks in that. So this was the context in which we were undertaking this study, knowing that we have a lot bigger risks here, different kinds of risks here, and that no prior analyses of risk reduction interventions has analyzed the data of Indigenous people. And in many cases, it wasn't clear if Indigenous people were even included. So we don't know if any of our available techniques work. So given colonialism, given cultural competency issues of given access, we wanted to really prioritize non-expert interventions that were not going to require someone with a PhD or even a bachelor's degree to haul out to the reservation and impose their potentially colonialist perspective of prevention on the reservation. Rather, what are things that can be peer-led? What are packages that can be presented to tribal elders for them to implement on their own? That's also consistent with how many sexual victimization risk reduction interventions are presented, of being peer-led. So the goal of this study was to use a mixed methods, intersectional framework to understand what do Indigenous people want in terms of sexual violence intervention programs, particularly the peoples of the Great Plains. And so we focused on gathering acceptability data on Flip the Script. This is Charlene Sen's EAAA program. And acceptability data on these peer, non-expert provided trauma and substance use interventions, with the idea that providing sexual violence risk reduction is going to need, in many cases, to co-occur with mental health recovery. So how did we do this? Today, I'll focus on the quantitative data, and that is data from 405 college students across North America. Many all identified as Indigenous, many identified as other racial identities as well. That sample is about 76% women, 16% men, and 7% two-spirit or trans. So that's about 80 men included, and something like 40, a little less than 40 two-spirit trans folks, just to math nerds in the audience. Our sample was mostly heterosexual, but again, a large number of people who identified as two-spirit or bisexual. And in Indigenous cultures, modern pan-Indigenous cultures, I should say, two-spirit is a pretty broad term that can mean a non-majority gender or non-majority sexual orientation. So we asked it in both places. The mean age of our sample was 24. Most of our participants were attending a tribal college and living on or very near a rural reservation. This data was collected from March to August 2021. We started out just recruiting in North Dakota and Oklahoma being where my co-PI is, but we did reach out to every single tribal college in the US. That meant applying for IRB approval at least 8 different institutions. I think we're up to 9 now, and trying to apply it more. Like, we reached out directly to the IRB in a lot of cases. And this was funded by North Dakota EPSCoR and the Lindsay M. Bonestall Foundation. So our quantitative data was an anonymous survey with 4 main components: acceptability of sexual violence interventions, sexual victimization history, mental health history and treatment preferences. And our survey order, because it quickly became apparent that many people were not going to finish, because it was a long survey and it's an upsetting survey, which we tried to account for, but it is what it is. So we did a fixed survey order of acceptability data first, and then randomizing people to blocks for the other components. So for the acceptability data section, we created 4 standardized descriptions of 4 different empirically supported interventions. So 4 descriptions, 4 interventions, not 16. I realize that's a little bit confusing, not 4 by 4, 4. That's Flip the Script, which is a self-defense and emancipatory sexuality intervention. This is the only one that has been subjected to a large-scale randomized controlled trial. I think like 1,000 people were in this study. Bringing in the bystander, which is not so much targeting individuals who want to change their risk, but community members and how can we make our community safer. What we called the Sexual Assault and Substance Use Reduction Program that Amanda Gilmore created and has been working. This is an online intervention in contrast to the other two being in person and group oriented. And then brief drinking intervention. Now, sexual violence interventions are a bit behind the times in terms of meeting APA guidelines for empirically supported interventions. So we tried to choose the things that had the most empirical support. Or in the case of the brief drinking intervention, seem to be potentially especially relevant for our population. So that's again a individualized, brief, peer-led intervention. So participants were given these 4 descriptions, asked to rank them in terms of what was most appealing, and then rated them on their acceptability for flip the script, and then the one that they rated number 1. And if they rated flip the script number 1, the one they rated number 2. After that, we gave participants a list of 23 different intervention components. So these are intervention components from those 4 interventions, as well as from other interventions that are out there. And rate each component in terms of how important they think it is for sexual violence risk reduction. And these components kind of fall into 3 rough categories of modality related issues. Is it in person? Is it online? Is it an individual? Is it a group? Some of this content is sexual violence specific in terms of, do they teach physical self-defense? Do they provide information about overcoming barriers to self-defense? And then some of these components are kind of other related content, like, is substance use addressed? Is it created specifically for Indigenous people? Is there individual counseling available? So those are our kind of basic procedures. Measures. So acceptability was assessed using the North Dakota Sexual Violence Intervention Acceptability Measure. This is a 10-item questionnaire that is anchored to SACON's acceptability framework. So assesses these 7 components: attitude, burden, ethicality, opportunity costs, perceived effectiveness. This is an open source measure that was created for a different study, but used in this one. Why we chose this was that most acceptability questionnaires were kind of created bespoke or ad hoc for that particular program. And since we wanted to be able to compare programs, we wanted to create something that had more flexibility to compare across programs, including across modalities. Preliminary testing suggests good validity, but also areas for improvement, consistent with Clark and Watson's model of measurement, that measurement should always be iterative and improving. For sexual victimization, we used the 2007 Sexual Experiences Survey with a scaled response format, and I've included an example item here. There's always a little bit of controversy in the field about how many items this is. According to the official SES, this item on the right is 1 item. Seems like more than 1 to me, but reasonable people can disagree about a lot of things. In any case, all of these items describe a sexual behavior. At the top is kind of the stem, and then below that, 5 ways in which that behavior could have been coerced. We assessed childhood sexual abuse with the Child Trauma Questionnaire, which has 5 items and has the instructions of thinking about when you were growing up, did any of these things occur before the age of 14? And then below is an item like, I was touched sexually, which is rated on a scale of 1 to 5, from never true to very true. Substance use intervention preferences were assessed with 6 items from the ND-SVIM, trying to create, again, some comparability there. And we randomly assigned participants to give us preferences about either motivational interviewing or 12-step programs. Again, with the survey burden issue becoming real apparent here. And again, we focused on things that could be peer facilitated. To measure actual substance use, we gave the DAST and the daily drinking questionnaire. So these are more measures, these are more for screening measures rather than being able to give a diagnostic assessment. So what did we find? And again, please drop in any clarifying questions you have in the chat. I don't want people to have to wait till the end to understand something. This is one of those things, the high burden of victimization on our sample, totally consistent with the literature, should not be a surprise. And yet, every time I collect data like this, I am just floored that there are entire communities dealing with this degree of harm. And in fact, in our sample, repeated developmental victimization, so having experienced childhood sexual abuse and adult sexual assault, was the norm. That was 67% of our sample. When we drilled down a little bit, so 78% of our sample reported adolescent or adult sexual victimization, 90% of those incidents were alcohol facilitated rape. And the gender differences that we found were not quite what you would maybe expect. We actually found men reporting more sexual violence than women in our sample. I'm guessing that has to do with the way our study was advertised, that perhaps was especially appealing to men who have been harmed in this way. And interestingly, Two-Spirit folks were at risk, greater risk for basically everything we measured except alcohol facilitated victimization. Still experiencing a very high burden of it, but less than compared to men and women. Because we're really interested in acceptability and what kind of interventions are people willing to do and interested in, we did ask a little bit about what have people done in the past. And many participants, about 40%, had already done self-defense at one point. This is consistent with data I've collected with white college students in Ohio. Of course, this is defined broadly, so we don't know a whole lot about what kind of self-defense that is. But nearly 50% had done some kind of sexual assault prevention program. And we didn't see a lot of gender differences in terms of prior participation, although Two-Spirit folks had less prior participation for self-defense and for bystander intervention. So what's the context of substance use in this sample? Lower than expected reports of risky alcohol use. If you use, kind of past week or past month or heaviest episode in the past month from the daily drinking questionnaire, 3.2% of men and 8.6% of women in our sample met criteria for risky alcohol use, which is way less than what you would expect with white college students. So the good stuff, what we all came here for, the intervention acceptability. So I've organized this table by the 4 programs, and then we asked separately, are you willing to do this? Are you not willing to do this? And then rankings. So you can see here that willingness to do it, to give it a try, ranges from the lowest, 54.7%, to the highest of 68.2%. And the Gilmore intervention, that was significantly different in terms of more people being willing to do it than the other interventions, but there was no difference between flip the script, breaking in the bystander, or brief drinking intervention in terms of willingness or unwillingness. So we see here that the Gilmore intervention is standing out in terms of who's willing to do it, and also the least number of people saying no, not interested at all. And the brief drinking intervention was the least likely to be ranked number 1. Oh, other thing I meant to mention here. Oh, no, that's on this side. Sorry about that. So next we looked at these preferences in terms of potential gender differences and potential differences for people with victimization histories. No gender differences at all. We did see some differences with victimization history. Again, the sexual assault and substance use intervention created by Gilmore being the thing that people were most willing to try. But also a thing that people with victimization histories were less willing to try. So for those 3 interventions in bold, people with victimization histories, this is just the average for the sample. Compared to that average for the sample, they were less willing to try. And then we also asked people about those specific intervention elements. And this was, again, somewhat surprising. We didn't have a lot of hypotheses here because there was just like no prior data to compare to. These were the 5 most highly rated elements: guaranteed privacy, actually learning physical self-defense versus verbal self-defense, identifying risky strategies, overcoming barriers. Like, the things that people are saying important are the things that scientists are also saying are really important. We did see some gender differences here in that women rated every intervention element more importantly than men, but they were still, everything was being rated very highly. So there was not much of an interpretive difference there. We were somewhat surprised to see that programs being created specifically for Indigenous people was kind of the middle of the pack. That was not a particular priority for the sample. Nobody's against it, but it's not the top 5. We also examined whether there were differences for those who had victimization histories. And those with victimization histories valued the online format, as well as getting some just kind of additional relationship and sexuality information more highly than those without victimization histories. And then those without victimization histories cared more about expert providers, cared more about privacy and confidentiality, defense strategies, and research support. Although again, everything is rated so highly, the interpretive difference, the kind of clinical difference here is small. So last bit of data I'll share is that we, again, randomly assigned people to collect acceptability data on motivational interviewing or 12-step programs. And you can see here, randomization, these numbers are not equal. And for some reason that Qualtrics has yet to be able to explain to me, in spite of random assignment of blocks, we have less data for this block than anything else. In any case, people felt positively about these programs. 86% rated motivational interviewing as neutral or better. That's 75% for 12-step programs. There were some differences here in that when it came to motivational interviewing, that kind of one-on-one thing, people had more preferences for the gender of the provider than they did for 12-step programs. And people wanted an Indigenous provider, and they wanted it offered in their community on their tribal lands. So discussion, kind of what's the takeaway here? I'll give you all my takeaway, but I'm super curious to hear in our group discussion of what some takeaways were for other folks. I think big picture, all of these interventions were moderately acceptable, but there was a clear standout. You know, the willingness to try ratings suggests that Indigenous college students are up to try lots of different things when it comes to stopping sexual assault. Even though these approaches differed, some were in person, some were online, some are individual, some are groups, some are about targeting an individual versus some about changing your community. But Gilmore's sexual assault and substance use individual online intervention had the highest willingness to try and lowest unwillingness to try ratings, which I think is really interesting because for a long time it's been kind of self-defense, self-defense, self-defense. Everybody needs self-defense. And some people are just not going to dig that. Some people are just not going to be into that. So what is the alternative for those folks who just self-defense for whatever reason doesn't appeal to them, but they want to be able to protect themselves? We have some solutions now. We didn't see a lot of gender differences here. And this is particularly stark when you think about compared to white men. If we did this same study with white men, Indigenous men, Indigenous college men get that sexual assault is a problem in their communities, for themselves, for their loved ones, and they're willing to try stuff. They're willing to work on this. More apparent were gender differences between two-spirit folks and men and women. Cultural differences, kind of TBD in terms of, are there specific cultural practices, cultural interventions, cultural leaders that should be involved in these interventions? But we're doing qualitative interviews right now that I hope really gives us some more information on what those practices should be. One thing that was really interesting to us was that, well, alcohol facilitated violence was alarmingly common, even though not many folks were reporting heavy alcohol use, which is not consistent with other literature. Unsurprisingly, PTSD symptoms were very focal. So most of our sample experienced developmental re-victimization. Most experienced alcohol facilitated rape. And again, this is very striking when you consider we didn't oversample for those with victimization histories. The study was open to all Indigenous college students, and still, these are the kind of numbers we're talking about. And it's not just sexual assault. 40% of our sample also reported losing a friend or family member to murder. And 69% of our sample screened positive for post-traumatic stress disorder on the PCL. Good news, Indigenous college students are not only just really open to lots of intervention strategies for sexual assault, they're really open to different substance use intervention strategies too. And I think this is particularly good news because things like motivational interviewing and 12-step programs, they're peer-led. And my take would be that those would be easier to integrate with trauma-focused therapies than some other kinds of treatments. Some of the limitations, I mean, we were doing this at the height of COVID. This data was an absolute bear to collect. Our study was attacked by bots, so we were constantly making adjustments to try to continue recruitment, but get less fake data submitted. And 83% of our samples said that COVID had them thinking about the loss of their people to disease on at least a weekly basis. So we were also sampling people at a time in their lives where they were really vulnerable emotionally. I do wonder if this suppressed drinking rates, that this was happening during lockdown periods. I'm also curious, we included a questionnaire on mistrust of researchers, and 33% of our samples said that they don't trust researchers. So I'm not certain what that means for our data yet in terms of did people really need the money? And so they did the study anyway, or are those folks' data different in some way? Watch this space for more information on that in the future. Some continuing directions. As I said, we're doing qualitative interviews to really further contextualize and round out this quantitative data. We still have lots of data to analyze. We also collected data on preferences for trauma interventions. We collected data on resiliency, which clearly this sample has buckets of. And we collected data on the impact of COVID, which my co-PI, Dr. Cole, is really interested in. So there's still a lot to be learned here from this data set. So to sum up, Indigenous college students are open to lots of different types of interventions, actually. And the combined substance use and sexual violence intervention was the thing that was most preferred. So we have this in common. We are on the same page in this way. And lots of qualitative data is in progress to further contextualize and specify what are the kinds of Indigenous specific cultural practices that could be incorporated to make these programs even better. So let's wrap up some further resources for anyone who is curious. These are, I think, some great places to start, particularly Sarah Deer's book, The Beginning and End of Rape, Confronting Sexual Violence in Native America, really lays the case bare that rape is a colonizer problem that has been going on for generations. So, Miigwech, thank you. And this is where I can be reached.